Hi, my name is Elizabeth Mickey. I'm going to be presenting my capstone project today. The topic is decreasing antibiotic use in neonates, primarily with the use of a neonatal sepsis risk calculator. So the objectives of this capstone project were to review the literature on early onset neonatal sepsis, also known as EONS, as well as find the best practices based on evidence for nursing care for this population. So the reason this topic is important to nursing care is that early onset neonatal sepsis is a significant potential cause of morbidity and mortality in neonates. So this is a large issue for the neonatal population, and it's something that we need to find the best evidence and the best practices to be able to implement to treat these babies accurately. So they found in reviewing the literature, they found that there's been a change in causative organisms for sepsis in neonates over 5 years. So there was a study done by Caltagirone, Nolan, Hickey, Greenough, and Kassim that found that the organisms that were causing sepsis changed from GBS or group B strep to E. coli. Part of the reason for this change was the introduction of intrapartum antibiotic treatment of the mothers. And part of the reason they feel was due to the overuse of antibiotics. So as the organisms became resistant to antibiotics, these organisms that were previously not causing sepsis were getting stronger and kind of overcoming the treatment and causing these babies to become sick. So the presented tool to help treat these babies adequately is a neonatal sepsis calculator. So we'll go into that a little bit more in just a minute, but in the evidence, they found in a study done by Piopolo et al. That risk factors for neonatal early onset sepsis are based on results of studies performed before this intrapartum antibiotic prophylactic treatment. So they found that the data that is used to develop the current guidelines for treating these babies is old data. So it's based on the causative organisms that were different, and it's based on different levels of risk because the baby's risks has decreased to be septic from GBS since this intrapartum treatment of mothers. So they found that the risk factor threshold values are resulting in large amounts of babies, uninfected, well babies being treated with antibiotics. And this can contribute to complications in newborns, immune effects based on them receiving large, broad spectrum antibiotics when they're very small, and as well as a community-based change in the organisms that are proliferating and getting stronger due to widespread use of antibiotics and organisms being able to kind of be exposed to them and grow accustomed to being stronger than them. So the exhaustive literature review involved searching electronic databases such as EBSCO and CINAHL. The keywords that were used were neonatal sepsis, antibiotic use in neonates, and sepsis calculator. The limiters were within the past 8 years, full text articles in English language. So the PICO question that was developed to base as the basis of this project was, in the neonatal population, does the implementation of a neonatal sepsis risk calculator for antibiotic use compared to the current neonatal sepsis guidelines for antibiotic use affect the sepsis rates in at-risk newborns during the first week of life? So this question was the basis of this study. It was not fully addressed based on kind of need for more data, but it was addressed in many ways. So our population was neonates. The intervention was the sepsis risk calculator. The comparison was the risk calculator study that's being conducted at a large acute care facility in the Southeast currently, and that was the setting for this project. And so the comparison between that and the current guidelines, as well as the outcome was, does this change the sepsis rate in at-risk newborns? And that is the main piece of data that's missing because the data is still being undertaken. and the time frame was during the first week of life. So what are some benefits of decreasing antibiotics? We kind of covered this a minute ago, but decrease antibiotic resistance, increase effectiveness of appropriate antibiotic treatment. So when you give antibiotics, you want them to work. So if you give them when they're not needed, there's more chance of them becoming ineffective. And finally, a large benefit would be minimizing unnecessary treatment of neonates and unnecessary complications, as well as unnecessary separation and disruption of the mother-baby bonding time immediately after birth. So what are some risk factors? Why would a baby become septic? So maternal chorioamnionitis is an infection that develops during labor and delivery. So the mother may have had prolonged rupture of membranes, and somehow bacteria entered in and caused some sort of infection. So that puts the baby at risk. Whether the mother was positive for group B strep, and if she was untreated or inadequately treated, which is considered less than 4 hours prior to delivery, in addition to one of two risk factors. So whether the baby was premature or ruptured membranes greater than 18 hours, that would increase the risk. Maternal GBS status unknown with other risk factors. So even if they don't know the baby was preterm or the membranes were ruptured for a prolonged amount of time, that will increase the baby's risk. And a maternal UTI at time of delivery can also impact the baby's risk. So the current best practice guidelines. The American Academy of Pediatrics, in conjunction with the CDC, have developed these recommendations. So for signs of sepsis, they recommend a full diagnostic evaluation be done on the baby and antibiotic therapy be begun as soon as you've collected the blood culture. So not waiting for results, you send the blood cultures and then you begin antibiotic therapy. In maternal chorioamnionitis, they do a limited evaluation and begin antibiotic therapy prior to the blood culture return as well. GBS prophylaxis, if the mother didn't have a need for it, if she was negative, then you just proceed with care. If the mother received greater than 4 hours of penicillin or like adequate treatment, same, you just observe the baby for greater than 48 hours or equal to. And then if the baby was term, but the rupture membranes was not prolonged, same, you just observe the baby. And then if the baby was preterm or had prolonged rupture of membranes, you do limited evaluation and you observe for greater than or equal to 48 hours as well. So those are considered the best practice guidelines for right now as a standard across the US. This is the algorithm for the study being done, and it involves, the main difference is, so if you have a baby with signs of sepsis, you're going to send the blood cultures and you're going to treat with antibiotics, but the clinical response cultures, and so there's some physician judgment involved in the treatment there. But in general, you're going to give antibiotics if the baby is showing signs of being septic. If the mother had maternal chorioamnionitis, you're going to send the blood cultures and you're going to use the sepsis risk calculator for the decision on whether or not to begin antibiotics at this time. So if the antibiotic culture, or if the cultures come back negative at 48 hours, then you just send the baby home. If the culture comes back positive, then you're going to treat at that point. So you're going to continue to monitor the baby. You're going to continue to do every 6-hour assessments. And any change in care, you're going to report to the care provider. Any result in the blood cultures, you're going to report to the care provider. But in general, you're going to go off of the risk calculator tool to determine their need for antibiotic treatment. And so that is the main difference. The rest of the algorithm is pretty similar. There are some instances where, again, you're going to use the risk calculator rather than just begin antibiotics. And so that's the main difference. Instead of your routinely, if this, then you give antibiotics, you're going to go off of an individualized score based on the tool. And so we're going to get into what that tool is in just a moment.